Good day, friends. This is Dr. Shivam, and we are going to discuss a case of carcinoma tongue. So, tell me, what is your case? This is a case of ulcerative type of carcinoma tongue on the right lateral aspect of anterior two-thirds of the tongue without any lymph node metastasis. Okay, tell me the summary. My patient, 60-year-old male patient, presented with an ulcer in the right lateral margin of the tongue for last 1 year. The ulcer was initially small in size, but for last 6 months it increased in size to attain the present size. The patient complains of excessive salivation for last 6 months, also complains of dull aching pain in the local site. He does not complain of dull any swelling in the neck. The patient is chronic smoker and is also a habit of chewing tobacco for last 8 years. On examination, there is 1.5 by 1.5 cm ulcer in the right lateral margin of the tongue. The margin is everted, base is indurated, and the floor of the ulcer is covered by necrotic slough. Movement of the tongue is normal, ulcer is not adherent to the mandible, and the cervical lymph nodes are not palpable. So tell me, what is your diagnosis? This is a case of ulcerative type of carcinoma tongue on the right lateral aspect of anterior two-thirds of the tongue without any lymph node metastasis. Can you tell me the differential diagnosis of an ulcerative lesion in tongue? Yes, sir. It can be traumatic ulcer, tubercular ulcer, infective ulcer, syphilitic ulcer, or aphthous ulcer. Okay, so traumatic ulcer, how? So traumatic ulcer usually follows chronic irritation by his sharp tooth or by any denture. Tubercular ulcer can be due to or may be associated with tuberculosis elsewhere in the body, and the edges will be undermined, floor covered with pale granulation tissue. Infective ulcer due to non-specific bacterial infection, and syphilitic ulcer very rare nowadays, but they will be painless, punched out ulcer, floor will be covered with washed leather slough. How you are going to manage your case? I will like to confirm my diagnosis, sir, by taking an incisional biopsy from the margin of the ulcer, a X-ray of the mandible for seeing the bony involvement, mainly a orthopentamogram, a indirect laryngoscopy to exclude lesion in the posterior third of the tongue, a chest X-ray to exclude chest metastasis, and some baseline investigations like complete hemogram, blood sugar, urea, creatinine, ECG, and equally important, maintenance of oral hygiene by antiseptic mouthwash. So tell me, what precaution should you take while taking an incisional biopsy? You told you will take an incisional biopsy. Yes, sir. The biopsy should be taken from the most suspicious area and can also be a guided one and should include some of the normal adjacent mucosa also. The biopsy should not be taken from necrotic or infected area, as result may be fallacious. Okay, so how you are going to treat your patient? Sir, I will consider surgical treatment in this patient. My plan is to do right hemiglossectomy along with elective lymph node dissection on the right side, removing the level 1, 2, 3, that is supraomohyoid neck dissection. Okay, would you like to do a hemimandibulectomy in your patient? Sir, the lesion in my case is confined to the lateral margin of the tongue and has not infiltrated the floor of the mouth or the mandible. So, I am not going to consider a hemimandibulectomy in this patient. If anyhow the lesion would have infiltrated the floor of the mouth, or if the lymph nodes are involved requiring MRND and bone involvement is there, then concomitant hemimandibulectomy may be required. Would you like to give postoperative radiotherapy to your patient? Yes. If the lines of resection are positive after the biopsy, it should be considered. But if the lines of resection are free of the tumor and the tumor is well differentiated, postoperative radiotherapy to the tumor is not required. While the patient should be kept under regular follow-up, and if there is recurrence, it may be treated with radiotherapy. However, postoperative radiotherapy is indicated if the primary lesion is very large, the grade is poor, the resection lines are involved with the tumor, and if there are two or more involved nodes with extracapsular extension, postoperative radiotherapy to the neck is required. Okay, do you know about prophylactic irradiation of the neck? What is its role? There is good evidence that elective irradiation of N0 neck with 40 grays is of same benefit as elective node dissection and carries less morbidity, so it can be thought before planning any surgery. What are the predisposing factors you think or you have studied for developing a carcinoma tongue? So it can be long-standing traumatic ulcer, as already told, for by the tooth or the denture. It can be due to leukoplakia, means predisposing ones, and the chronic irritation like smoking, spirit, spices, syphilitic glossitis, chronic superficial glossitis, erythroplakia, Plummer-Vinson syndrome, papilloma, and many others. What are the relative side distribution of carcinoma tongue? Sir, it can be 25% for posterior one-third and 75% for anterior two-third. And among anterior two-third, the lateral margin alone contributes to 50%, the dorsum 5%, tip 10%, and the ventral surface 10%. What are the gross type of carcinoma tongue you know? Sir, it can be ulcerative type, exophytic or papillary type, nodular type, and fissure type. Can you tell me some detail about them? Yes, sir. The ulcerative type, ulcer is initially superficial, later on typical ulcer with irregular everted margin with indurated base and floor covered with necrotic tissue and bleeds on touch. Exophytic or papillary type is the papillary tumor with a broad and indurated base and has a papillary lesion with central ulceration. While the nodular type will be present as a submucous nodule which may ulcerate later on. The fissure type presents as an ulcer in the depth of a fissure. Okay, very good. What are the histological types of carcinoma tongue? So there are 4 types of histological carcinoma tongue. It can be squamous cell carcinoma, which is the commonest, basal cell carcinoma, adenocarcinoma, and malignant melanoma. Why there is a speech problem in patients with carcinoma tongue? The growth may cause deeper infiltration of the muscles of the tongue and floor of the mouth, resulting in restriction of tongue movement and difficulty in articulation. Okay, so tell me, how does carcinoma of tongue spreads? The spread can be defined as direct spread or local spread, lymphatic spread, and the blood spread. Okay, so tell me where it can spread to. Sir, it can spread directly or local spread to the floor of the mouth, mandible, tonsil, epiglottis, lymphatic both by lymphatic permeation and lymphatic emboli. It may metastasize to submental, submandibular, jugulodigastric, and jugulo-omohyoid lymph nodes. Okay, and by blood, although is a rare route of spread, it may metastasize to lung, liver, and bones. Okay, so you have answered many questions. Now tell me, what is T definition of AJCC staging of oral carcinoma? Yes, sir. Tx is primary tumor cannot be assessed. T0 is no evidence of primary tumor. TIS is tumor in situ. T1 is tumor less than or equal to 210 cm in greatest dimension. T2 is tumor greater than 2 but less than 4 cm in greatest dimension. T3 is tumor greater than 4 cm in greatest dimension. T4 is tumor invading adjacent structures. Good. Now what is N definition in a similar way in AJCC staging? Okay, sir. NX is regional lymph node cannot be assessed. N0 is no regional lymph node metastasis. N1 is metastasis in a single ipsilateral lymph node less than 3 cm. N2 is divided into N2A, N2B, and N2C. N2A is metastasis in single ipsilateral lymph node greater than 3 but less than 6. N2B is metastasis in multiple ipsilateral lymph node, none greater than 6 cm. N2C is metastasis in bilateral lymph nodes or contralateral lymph nodes but greater than none greater than 6 cm, and N3 is anytime metastasis to lymph node when greater than 6 cm in diameter. What is M is definition in AJCC staging? MX distance metastasis cannot be assessed. M0 no distance metastasis, and M1 is distance metastasis. Okay, now tell me, what structure will you remove in a radical neck dissection? The radical neck dissection was described by Kreil in 1906 and involves removal of all the levels of lymph node starting from level 1 to level 6, sternocleidomastoid and omohyoid muscle, IJV, spinal accessory nerve and cervical plexus of nerves, submandibular salivary gland and tail of parotid gland, and all the intervening lymphoareolar tissues. What structure will you preserve in MRND dissection? Sir, it removes all the lymph node as in the radical node dissection, but we preserve any one of the non-lymphatic structures removed in radical neck dissection like spinal accessory, internal jugular vein and sternocleidomastoid muscle. It is further divided into type 1, 2, 3. Can you name them? Yes, sir. Type 1 is when spinal accessory is preserved. Type 2 is when spinal accessory and IJV are preserved. And type 3 is when all the three spinal accessory, IJV and sternocleidomastoids are preserved. Okay, now tell me what is functional neck dissection? You told both, so you must be knowing this also. Yes, sir. Functional node dissection is a variation of MRND where a group of lymph nodes from level 1 to 6 are removed and all the non-lymphatic structures are preserved. Okay, good. So what do you mean by elective neck dissection? Sir, elective neck dissection involves removal of cervical lymph nodes considered to be high risk for metastasis from a given primary site. The extent of this dissection depends on the primary lesion. Selective lymph node dissection is usually performed in N0 neck. Okay, so what is the role of radiotherapy in treatment of N0 neck? Radiotherapy is an effective modality of treatment for N0 necks when the lymph nodes are not clinically palpable. The result of surgery and radiotherapy are although comparable. If primary lesion is treated by radiotherapy, the neck nodes may be irradiated electively. Okay, so how does the lymphatic of tongue drains? As you have told you are going to do neck dissection due to metastasis in lymph, tell me the lymphatics of tongue. So the tongue has a rich plexus of lymphatic. The lymphatic from the tip may drain into the submental lymph nodes on the either way. The lymphatic from the lateral margin and from the undersurface of the anterior two-thirds of the trunk drain into the submandibular, that is 1B, jugulodigastric, that is 2, and jugulo-omohyoid, that is 2B of the group of lymph nodes. The level 2 lymph nodes are the most commonly involved lymph nodes in the metastasis from CA tongue. The level 1 and 3 are at higher risk for metastasis for CA tongue. In patients with N0 nodes, dissection of 1, 2, 3 is sufficient to assess the status of the lymph node with squamous cell carcinoma tongue. Okay, so tell me what are the different lymph nodes in the neck? The cervical nodes are situated superficial or deep to the deep cervical fascia and thus grouped as superficial or deep cervical lymph nodes. The cervical lymph nodes are described as 6 levels of lymph nodes. The level 1 as submental, 1A, submandibular, 1B. Level 2, 3 and 4 are lying in relation to the upper, middle and lower thirds of the internal jugular vein. Level 5 is those lymph nodes which lie in the posterior triangle of the neck. 6 is paralaryngeal and pre and paratracheal lymph nodes. Level 6 is anterior mediastinal lymph nodes. What is the cause of earache in patients with CA tongue? Sir, it is usually and most commonly a referred pain due to infiltration of lingual nerve, and the pain is referred via the auriculotemporal nerve, which is a branch of mandibular division of the trigeminal nerves. So mainly it is a referred pain via the auriculotemporal nerve after the infiltration of lingual nerve. Okay, so what is the cause of excessive salivation you were giving in the history? Often patients of carcinoma tongue presents with excessive salivation. This may be due to excessive secretion of saliva due to irritative lesion in the tongue, or it may be due to difficulty in swallowing of saliva due to restriction of tongue movement as a consequence of ill filtration of the floor of the mouth. Okay, so what is the treatment of choice for early carcinomatous lesion in tongue? Sir, early carcinomatous lesions of tongue less than 1 cm may be best treated by surgical excision with 1 cm margin all around. And what are the treatment of choice for intermediate? For intermediate, the outcome of surgery and radiotherapy both are comparable, although we need to investigate and The final decision rests upon the surgeon. How will you manage a defect following excision of tongue? If less than one third of the tongue is being excised by us, a formal reconstruction is not required as such. The area following excision is fulgurated and allowed to granulate and re-epithelize spontaneously. Or, sir, this area can also be covered by a split skin graft. If we perform a hemiglossectomy or two-thirds of the tongue is resected, reconstruction may be done with a free radial forearm flap with microvascular anastomosis. And if we are doing a very large volume glossectomy or near total or total glossectomy for deep infiltrating lesion with resection extending up to the hyoid bone needs to be repaired or reconstructed with the bulky flaps to fill the dead space. A pectoralis major myocutaneous flap is the best in such situation. Okay, so suppose your patient have a growth in posterior third of the tongue. How you will manage? Carcinoma involving posterior third of the tongue are usually advanced at the time of diagnosis and are usually best treated by radiotherapy rather than surgery. What may be the cause of lymph node enlargement in a patient of CA tongue? Actually, sir, the lymph node enlargement is either due to infection or metastasis. A course of broad-spectrum antibiotics is given for 2 weeks and observed. The infective lymph nodes will regress. The FNAC will confirm the metastasis disease. Okay, if lymph nodes are not involved clinically, how you will treat the lymph node in patient with carcinoma tongue, carcinoma lip, and carcinoma floor of the mouth N0? Here, the management of clinically impalpable node in this clinical situation is controversial. There are proportions for prophylactic neck dissection when the lymph nodes are not clinically palpable, and the justification can be given by different studies. So in N0, a supraomohyoid block dissection is sufficient. What are the points against prophylactic neck dissection? Actually, sir, the incidence of positive node in prophylactic block dissection exceeds the incidence of subsequent clinical nodal metastasis. Some micromets in lymph node possibly are destroyed by body's own defense mechanism. Other thing which we can see is the primary tumor may recur or a secondary primary may develop, and the metastasis to dissected neck may make subsequent management difficult. The block dissection of neck has a considerable morbidity and some mortality. Okay, how you will treat a patient of carcinoma with mobile node metastasis, that is N1 and N2? So, patients with carcinoma tongue and oral carcinoma often has bilateral nodal metastasis. In those cases, a radical neck dissection on the ipsilateral side and the supraomohyoid neck dissection on the other side is indicated. IJV on one side should be spared. What are the indications when you will provide radiotherapy to your patient? Postoperative radiotherapy is indicated when there are multiple lymph node mets on histology, there is extracapsular extension of the tumor, locally advanced primary lesion not amenable to surgical treatment, then both the primary lesion and the lymph node met may be treated with irradiation. If the patient is unfit for surgery, the lymph node metastasis may be treated with radical radiotherapy. Okay, so I am giving you a case how you will treat a patient of carcinoma tongue with lymph node metastasis which are fixed, that is N3. Large fixed lymph node metastases are often associated with advanced primary disease with poor prognosis. Most cases are treated with irradiation both for primary and lymph node metastasis. A course of preoperative radiotherapy may render the fixed node in the neck to become mobile and may be amenable to radical neck dissection. Okay, the second case, a patient of carcinoma tongue treated with surgical excision came with metastasis lymph node in neck in follow-up. So how you are going to manage it? A detailed clinical examination at that time to exclude local recurrence and metastasis disease in other sites is important. We have to do an FNAC from the lymph node, a radical neck dissection. Nowadays, PET scan is also very useful to assess this. The metabolic activity of the nodes will tell us whether it is a metastasis or a local recurrence. and FNAC will also tell us. The radical neck dissection is basically the treatment of choice and post-operative radiotherapy if there are multiple lymph node metastases and if there is extracapsular extension. So, what are the different techniques for administration of radiotherapy? Can you elaborate? Yes, sir. The radiotherapy may be administered either by brachytherapy with implantation of radium needle, radioactive tantalum wires, or 192 iridium wires. They can deliver very high dose of radiation locally. The radiation needle can be kept for 9 to 10 days. Other is teletherapy, that is the external beam radiation with telecobalt or linear accelerator. Okay, good. Now tell me, in worst case, what are the causes of death in a patient of carcinoma tongue? So, the advanced cases or diseases may lead to death when hemorrhage from primary growth or hemorrhage from erosion of carotid artery in IJV by metastatic lymph node, or asphyxia resulting from growth in tongue or huge lymph node metastasis blocking the upper airway pathway, and edema of the glossus may aggravate the airway obstruction. Other thing is by aspiration bronchopneumonia, as the patient is not able to swallow properly, starvation, malignant cachexia, and many others like this if not managed at right time and the patient presents to us very late. Okay, so you have answered very good. Thank you for your patient listening. This is Dr. Shivam signing off.